Whatever may be the source of your preparation, in this video we are going to cover the topic fungal infections in a rapid revision manner. Hello dear students, myself Dr. Maddineni Srinivas. Welcome to Crack Derma with DrMSD. So let us begin our discussion with the P versicolor. It is Pityriasis versicolor. It was previously called as Tinea versicolor. So what is the most common causative organism? You remember it is Malassezia species related disease, Malassezia globosa and furfur. So what are the clinical features? Remember versicolor, so both hyperpigmented as well as hypopigmented macules will be there perifollicularly, and there will be fine scaling, and this scaling is described as furfuraceous scaling or brany scaling. Often the site is going to be the trunk or chest, which will be mentioned. Investigations, KOH mount is going to show the characteristic spaghetti meatball appearance. Wood lamp examination, yellow fluorescence. Management, topical antifungals can be used, selenium sulfide lotion can be used, azoles can also be used, orally itraconazole can also be used. Next is candidal infections. Remember it is candidal albicans, which is the most common cause, and factors involved are going to be diabetes in immunosuppression. Oral candidiasis is going to present as white curd like plaques which are going to be adherent to the mucosa, and they can be easily scraped off. This is the important difference between the candida and the oral hairy leukoplakia. Oral hairy leukoplakia is caused due to the virus Epstein-Barr virus, and it is going to produce again the same white colored plaques, but they are going to be present on the lateral aspect of the tongue and they are not easily scrapable, whereas in candida they are easily scrapable. Next is vulvovaginal candidiasis. It is going to present with itching in the female patients, and there is going to be thick curdy white vaginal discharge. Intertrigo, whenever candida is going to affect the skin folds, that for example the neck folds and also the web spaces, we call it as candidal intertrigo. And atrophic candidiasis can present as red colored plaques instead of white plaques in the mucosa. So investigations, you all know from microbiology, KOH mount is going to show the budding yeast cells culture on Seborrhoea's agar. Management is going to be topical clotrimazole, nystatin, and orally we are going to use the fluconazole. Partner treatment in the case of vulvovaginal candidiasis is not required because candidiasis is not considered a sexually transmitted disease. Can you tell me what are the other diseases which are not sexually transmitted diseases but are discussed under sexual transmitted diseases topic per se, the vaginal discharge topic? If you remember the disease, please put your answer in the comment section. Tinea capitis, so if the dermatophytic infection occurs over the scalp, we call it as Tinea capitis, and it is going to produce 4 types of presentations. But before that, just broad points about dermatophytic infections. Microsporum is going to spare the nails and epidermophyton is going to spare the hairs. Next is clinical features. In the clinical features, like I have told you, there are 4 types. Chirion fevers are associated with scarring alopecia, and they are going to produce the permanent hair loss. And remember, Tinea capitis is associated with alopecia, that is hair loss in all the types, but fevers in chirion, it is permanent hair loss. Chirion, what are the important points you need to remember? Boggy swelling. So these are all buzzwords. Boggy swelling over the scalp, easily pluckable hair, lymphadenopathy. Related to fevers, trichophyton Schonleini, it is scutula, which is a yellow colored crust present over the scalp. Black dot, grey patch are the 2 types of Tinea capitis which produce non-scarring type of alopecia or non-cicatricial alopecia where the hair loss is reversible. So black dot is an example for endothrix type of the Tinea capitis, and the causative organisms are trichophyton tonsurans and trichophyton violation. Next is the grey patch variety of the Tinea capitis, in which you remember it is ectothrix variety. Literally there will be grey colored patchy hair loss in these patients, and Microsporum canis is a causative organism. Management of Tinea capitis, remember griseofulvin is the overall drug of choice, but specifically if the examiner asks drug of choice for trichophyton related Tinea capitis, T for trichophyton, T for terbinafine is going to be the answer. And the topical antifungals are adjuvant in this case, Tinea capitis. Next is Tinea corporis, cruris and pedis. Remember the causative organisms could be rubrum trichophyton, verrucosum. And clinical features, corporis, I hope all of you know, there is going to be annular lesion with peripheral activity and central clearing, very important characteristic description. Tinea cruris is also called as thobe itch or jock itch, and erythematous rash with severe itching will be there in the groin folds. Tinea pedis is also called as athlete's foot, and there is going to be maceration in the web spaces. Usually the fourth web space is commonly associated. Investigations KOH mount is going to show the fungal heaven. Management of the Tinea cruris corporis, we are going to use the antifungals. Topical azoles can be used, oral terbinafine itraconazole can be used. And if the patient of tinea uses steroids, then that tinea is called as tinea incognita because it is modified and we can easily diagnose that condition. So next is sporotrichosis. So these are the implantation mycosis, very important. Sporotrichosis, Chromoblastomycosis and Mycetoma. Sporotrichosis, causative organism Sporotrichia, and it is also called as rose gardener's disease associated with thorn prick. And clinical features, it's going to produce the linear lesions along the lymphatics, so we call it as sporotrichoid pattern. And can you remember any other diseases where sporotrichoid pattern of lesions are there? Put your answer in the comments if you can remember. Investigations, KOH mount is going to show the fungal organisms, and if you do a biopsy we can see the presence of asteroid bodies. Management, it is a fungal infection, itraconazole is going to be the treatment. Chromoblastomycosis, remember here the causative organisms are pigmented fungi, that's the reason why it's called chrome is color. So Fonseca pedrosi, Fialophora verrucosum, these are the organisms. And here the lesions are very characteristic. They are going to be cauliflower-like or verrucous rough surface lesions present wherever there is a traumatic history. And investigations, very important names. We can see the copper penny bodies, medullary bodies, muriform bodies, or sclerotic bodies. Management is going to be with antifungals. Okay. Next is Mycetoma, also called as mother of foot. Here there is characteristic causative organism can also be a bacteria, where we call it as actinomycetoma, where Nocardia brasiliensis, streptomyces could be the causative agents. Coming to Eumycetoma, it is due to the fungi, and we all know it is Mozzarella mycetomatis. Clinical features, it is going to present Mycetoma will present with a triad of GST. There will be granules coming through the sinuses, and there is going to be tumor, that is a swelling of the tissue wherever there is a traumatic invasion of this fungi or bacteria. And you can remember GST, granules, sinus tracts, and tumefaction or tumor. So remember, if the grains are black in color, most likely it is going to be Eumycetoma, but if they are pale in color, most likely it is due to the bacteria, so we call it as actinomycetoma. KOH and fungal culture can be used, and bone involvement can also be present, so it is a very deep infection, and remember imaging can also be done to diagnose this condition. Management is going to be very interesting. Here Eumycetoma, fungal, so antifungals will be used, itraconazole commonly. And if it is bacteria, we are going to use this regimen which is called as Welch regimen, which consists of antibiotics, antibacterial agents, and we have a modified Welch regimen in which we are going to use the cotrimoxazole, amikacin and rifampicin combination to treat the patients. Stain used for the fungal element identification is methenamine, gomorimethenamine, GMS, gomorimethenamine silvestre, dye most suitable for biopsy demonstration of the fungi. It is going to be PASPeriodic acid shift, and dermatophytic infection is superficial where there is going to be involvement of stratum corneum. I hope this video was helpful. If so, please do hit that like button, also do subscribe, and the other videos are available in the form of a playlist link. I will keep the link in the description, also the comment section. Thank you so much. Happy learning. Sarvam Sri Krishna Sarvejana Sukhino Bhavantu. Bye bye.